One sector that is about to fully exploit the opportunity of 2D barcodes is the Australian healthcare sector. The pandemic has shined a light on the importance of our healthcare supply chains, from personal protection equipment to vaccine and to medicines. Many governments around the world have implemented serialization and traceability regulations to support efficiencies in their healthcare supply chains. In Australia, the Department of Health and Aged Care has started a consultation process to develop a framework for medicines traceability in Australia. And also the Therapeutic Goods Administration, the Therapeutic Goods Order 106 for medicine serialization comes into effect in January 2023, and also requires specifically the use of 2D barcodes. In this case, the use of GS1 data matrix. Our keynote speaker for today, Michael Hadron from Aspen, Australia, has been on this journey for several years, having been responsible for implementing serialization at Aspen between 2018 and 2020. Michael has 18 years experience in the pharmaceutical industry and joined Aspen as a project manager in 2012. He has delivered a diverse range of projects, including major capital works, contract manufacturing, tender submissions, and the transfer of a large portfolio of consumer and OTC products into this Aspen facility. So Michael is going to share with all of us his experience in implementing item-level serialization, 2D barcodes, and traceability systems based on GS1 standards. A very warm welcome to you, Michael, and over to you.
Thank you very much, Marcel, for the introduction, and thank you to GS1 and NGTAG for the opportunity today to share some of my insights into the topic of serialization and how GS1 standards such as the data matrix 2D barcode are being used to tackle issues of counterfeit pharmaceutical product and to enhance traceability in global markets. Today, I'll briefly cover what serialization is, why Aspen implemented it, and how the system works for us and our contract partners for which we manufacture product. I'll also talk about how the system can be expanded upon and also some of the implementation challenges that can be faced. Just firstly, a little bit about us, Aspen Australia. So we commenced operations in 2001 with our headquarters in Sydney. We're a wholly owned subsidiary of Aspen Pharmacare, which is headquartered in South Africa. Aspen Australia operate a pharmaceutical manufacturing facility located in South Dandenong in Melbourne, which is where I'm based. And we make a whole host of different products, including prescription, specialty, over-the-counter and grocery products, both for local and for export markets. And in the past 4 or 5 years, we've really seen a huge expansion in our contract manufacturing business. Why we implemented serialization? As part of that expansion of our contract manufacturing business, we did undertake a huge portfolio of products that were being sold into export markets, predominantly into the Middle East, but also to the United Kingdom and to South Korea as well. So this was a huge expansion of production that had a future requirement for serialization at the time. We sort of started that journey in 2018. At that point in time, the EU hadn't gone live with their what's called the Falsified Medicines Directive, which was the mandatory timeline for EU countries to implement a serialization of pharmaceutical product. So that occurred in 2019, and we had production that was going live in 2020/2021 that would require serialization in not just EU markets, but predominantly in the Middle East. So that is why we went down the path of implementing serialization. Firstly, what is serialization? And just building upon what sort of Marcel introduced in that space. So serialization as it applies to pharmaceutical products is the application of a 2D barcode onto packaging, which contains a unique identifier. And that unique identifier is traceable from the manufacturer and the brand owner right through to the consumer. And this enables verification of drug authenticity. So at its heart, it's an anti-counterfeiting measure. In most global applications, what is used to carry this is a GS1 data matrix, and this is encoded with 4 pieces of information. Firstly, there's the Global Trade Identification Number, or the GTIN, which identifies what the product is. There's the expiry date of the product, the batch number, and then very importantly, the unique serial number that is applied to every pack. The type of serialization that we implemented at Aspen is what's called the point of dispense authentication, or the PODA model for short. So this is essentially the generation and transaction of serialization data at a sales unit packaging level. And just to sort of unpack what this slide is showing. So in the top left corner, we have the contract manufacturing organization, which is ourselves as a manufacturer of product on behalf of brand owners. And the traditional flow of product, which is shown by the blue arrows along the top there, is that we produce product. It goes into distribution through sort of third-party logistics into export markets, which is managed by our brand owners. That then gets sold into the retail sector, into pharmacies, and then those products end up being purchased by the consumer. So with serialization, there has to be a flow of data that supports that physical flow of product, which is shown by the red arrows in this diagram. So where we produce physical product, we print the encoded data matrix with those elements of information, including the serial number onto every pack. When we sell that to the market authorization holder or the brand owner, we send all the data associated with those physical packs that we've sold to them, and that's essentially what we call the commissioning of the serial numbers. That means we provide the serial numbers with all the batch specific details to the brand owner. And then when the brand owner sells and supplies that product into the markets where they sell that product, they undergo a process called reporting, where they then share the data for those serialized packs into the national database or regional database for that market regulator. So then what that enables is at the point of sale, the pharmacist can scan the data matrix on that pack, and it will authenticate that serial number and the details of that pack against that database, and will verify that that pack is genuine. And it will also potentially check as well that it's not a duplicate, so it hasn't been scanned out multiple times, and that obviously that it exists in that database to begin with. So that's how it closes the loop and provides that anti-counterfeiting measure. Just a snapshot of the markets that we currently supply to via our brand owners, and just to look at how the maturity of serialization progresses in different markets and how it does sort of follow sort of a staged approach. So generally for the export markets, the first thing that needs to be developed is the regulations around how data matrix or 2D barcodes are printed onto packs, and then that progresses to serialization, which is that second column there, where manufacturers have to provide unique serial numbers to be encoded into those data matrix, and that for manufacturers and brand owners to actually generate and maintain data of those unique packs. That then progresses to reporting, which is where the brand owner then has to provide that data to the market regulator to close the loop on product authentication, which would enable those packs to be scanned and verified at the point of sale. The final step of that journey is aggregation, which I will touch on a little bit later on in my presentation, which provides traceability through various stages of the supply chain. So you can see there across the different markets that there's some of them have achieved that full maturity, and some of them are sort of going through the process of getting there. So with regards to the infrastructure that we've implemented at our facility, it follows like a traditional model of the serialization hierarchy, which is talked about levels 1 through to 4. So the level 4, which is otherwise known as the enterprise level system, is we use an application called TraceLink. So this is the system which is the kind of the brains of the serialization system. It's a cloud-based repository where we maintain pools of serial numbers, and it is also the business-to-business interface with our brand owners for sending and receiving serialization data. Sitting below that is what we call a level 3, or a site level server application, where we use an application called Vimichem, which is used for batch management at a site level. It's the layer that we as a manufacturer deal with most often for generating creating batches of of serialized products and then issuing them to production lines. And then sitting below that is what we call the level 2 or the line level controllers, which are really at the cold face of serialization. So they receive the serial numbers for each lot that we need to manufacture. They issue each serial number to each pack. It prints and verifies the packs. And then at the end of the batch, it assigns the disposition of all those serial numbers, whether they were good or bad, to the site level server. I'll get it a little bit more into some further detail on that in the subsequent slide. So that's our infrastructure. When we were going through the process of implementing our system, we did have several selection criteria, and this is, I guess, really important for anyone that is looking to undertake this journey. So one of the key selection criteria we had was around we wanted a system that was flexible. So when you implement such a system, it does become very sort of ingrained in your operation. So we did a lot of due diligence up front to make sure we were going for a system that was going to be very flexible to our needs, and that's where we found a lot of suppliers have very proprietary type solutions, where we sort of went for something with a universal interface that between the different tiers of the system, we could in the future change either the software or the line level solutions and have the ability to mix and match different systems. Scalability was the next important piece. We certainly wanted a system that we could initially deliver the point of dispense authentication model, and then in the future expand on it by either adding more packing lines or more capability onto those existing packing lines to implement fully aggregated solutions. Of course, ease of use was a big factor. There's many stakeholders in the organization that have to work with this system. It has to be quite intuitive and not overly complicated, given this is not just being used by the production planners for issuing batches to lines, but obviously all the factory operators have to work with this system as well. What I call a balance of ubiquity and innovation. Obviously, you want to sort of go with tried and tested solutions, but also given there's sort of early adopters in other countries where they've had milestones for delivery before us, we've had the opportunity to kind of learn from other companies, implementation challenges, and also look for options that sort of gave us a bit more innovation to get around some of the issues that other people have had when they've implemented serialization solutions. Implementation support from suppliers is important, and the customer service from the different serialization solution providers. So that was a big factor we considered. And then, of course, as well as the cost, both of implementation and ongoing costs as well for the solution. So in terms of the workflow and just sort of breaking it down at how it works for us as a contract manufacturing organization, it begins with TraceSync, which is our enterprise level solution. And within that, we maintain a pool of serial numbers per product, so essentially per GTIN. And that pool is replenished from our brand owner. So it essentially has a minimum maximum threshold. When we draw down that pool and it goes below the minimum threshold, it automatically gets replenished from the brand owner's enterprise level system. When we're ready to produce a batch of serialized product in Vimachem, in our site level serialization system, we create a batch, we assign a quantity to it, and then automatically it draws down from the cloud-based pool the required number of serial numbers, and they essentially get into a reserved state in TraceSync, which means they cannot be inadvertently allocated to any other production batches, so that makes sure that those unique serial numbers are only assigned to that batch. When we're ready to actually produce that batch physically on the line, from Vimachem, that batch is assigned to the production line, and all those unique serial numbers are then pushed down to the line level or the level 2 system. Then when we're physically producing the packs, we're in this example here, there's an image of one of our blister lines, so we're producing packs of pharmaceutical product. They roll through this machine. It typically applies tamper-evident labels to the packs and then prints the unique barcode and human readable text onto that pack, and then immediately acquires an image of what was printed on that pack, decodes that data matrix, reads all the human readable text, and makes sure that it was printed correctly and decodes correctly. And if all that's good, then that pack is accepted. It rolls off the machine. If there was any issue with that pack and how it was produced, it rejects that pack automatically, and also marks that serial number as not okay, which is the terminology used on that machine. And you can see the screen there as it sort of keeps track of the packs, classifying them as okay or not okay. So then once the batch is finished, we close the batch on the line. It then sits at that site level server application And then essentially for that batch, we end up with a certain number of accepted packs for which were saleable, a certain number of rejected packs for which the serial numbers were classified as not okay, as rejected, and then there will be always a residual amount of serial numbers that were not used. So then while batch release is pending at our facility, the serial numbers and their disposition is held at a site level, and just to provide clarity, still at that enterprise level in TraceLink, that set of serial numbers that were assigned for that batch are still sitting in a reserve state. That is, their final disposition has not yet been assigned while we're still performing batch release, because of course there might be the risk that we, for some other reason, need to reject that batch if something else has gone wrong, and then in that case, then all the serial numbers would be deactivated. So once quality release occurs, that batch essentially, we use the terminology, it gets commissioned into TraceLink, and then the final disposition of all those serial numbers that were associated with that batch of product get assigned. So all the accepted batches, accepted serial numbers for saleable units get commissioned in TraceLink. All the rejected packs, those serial numbers get deactivated, and then any of the residual serial numbers that were not used essentially get changed from a reserve state back into a unreserved state in the pool, and they can then be allocated to future production. The final stage of the contract manufacturer workflow that we follow, when we actually physically export the stock to our brand owner, we then send them the data associated with those packs as well. So that final step is called a shipment transfer event, and that is encapsulated in something called a GS1 electronic product services information file, or an EPSIS file, and that contains all the event data that supports the commissioning of each of those packs. So that includes the time and date stamp of when that pack was commissioned, where it was commissioned. So it has a global location number, which is another GS1 standard of where it physically was commissioned. So in our Aspen facility, and a product owned by our Aspen company, and that it shows that that product was then shipped to our brand owner, and it includes their GON information as well. So it sort of captures that movement of product from one entity to another entity. So having first implemented the PODA model, so serialization at a sales unit level, the next potential thing we could implement is what's called aggregation, or otherwise known as full track and trace, where serialization does not only occur at a sales unit level, but it also occurs at higher packaging levels. So things like potentially at a bundle level, at a case or shipper level, or at a pallet level. So with aggregation, it does require sort of more equipment and more sort of systems on each line, and it also does require more capability through your supply chain to sort of monitor the movement of stock distribution. But essentially what this allows you to do is establish child to parent relationships between your high level packaging components, so things like a pallet, right down to your sales unit. So by tracking the movement of a pallet through your distribution, you can essentially then have visibility of each individual pack through your complete supply chain. So I guess the system Aspen have implemented, it can easily be built upon to achieve this, but we're sort of not yet at that level. So I guess the implementation benefits, I guess first and foremost, is the mitigation of counterfeit medicines in global markets, and that essentially achieves increased consumer safety, which is is what the heart of serialization. As a manufacturer in Australia, it's obviously opened up our ability to export into pharmaceutical markets around the globe, which many of them now have mandated serialization and have got a common requirement for GS1 data matrix barcoding as part of that serialization solution. So it's really good for us as a manufacturer to be able to supply almost anywhere in the world now. It's also the first major step towards going to that next step of having a fully aggregated solution. Some of the implementation challenges that we faced, and that I think most people would face going down this journey, is the validation scope. So essentially verifying that the system works as intended is quite an extensive exercise. Obviously, there's a lot of regulations, quality regulations around the implementation of such a system, so that the documentation and verification is quite a big workload. Obviously, there's a lot of stakeholder management, both internally to the organization, externally, as well as, because it is a multi-tiered system, there's a lot of different solution providers involved, and this system touches a lot of the different departments in your organization, which flows into the generation of operating manuals, SOP, and then user training and embedding all those workflows. So it's quite an undertaking, but if well managed, the journey is of course well worth it. So just to summarize, we started our journey in sort of late 2018, and our system went live in July 2020. So it was about a 2-year implementation, with a big portion of that being sort of fact-finding and doing quite an extensive tender for the solution that we wanted. We now have 5 packing lines serializing product, and we're actually in the process of adding 3 more serialized packing lines by 2023. So we will have 8 lines running with this capability. So finally, this is my final slide. So essentially, Aspen have worked with GS1 to do a bit of a case study for our implementation. It goes a little bit more in depth as to sort of our implementation journey, and that will be published as part of the GS1 Healthcare Reference Book for next year. So those sort of wanting to learn a bit more about our journey, you're welcome to look that up, and I'm sure through this forum some further detail might be provided. But thank you very much for the opportunity to talk today.
We're going to move into a panel session. My name is Barry McGuckin, and Marcel introduced me earlier. I'm the General Manager for Food Innovation Australia and the Innovation Manager for Food Innovation Australia, and I'm on the steering committee for NGTAG. And I have the opportunity today to host the panel session. We have quite a broad set of topics for our expert panel this afternoon. We've got looking at patient safety, traceability of medicines. What does the 2D barcodes mean for government, and things like biosecurity and emergency response? Let's move into the panel. And to do that, first, I'm going to introduce our panelists. We've all met Michael just now, but our next panelist is James, and James has worked in community pharmacy and has been an accredited home medicines review pharmacist, and has worked in clinical hospital pharmacy as an assistant director of pharmacy overseeing inventory and information systems, and has had statewide roles to improve Queensland health digital ecosystem. Our next panelist is Paul Hansen, who's the director of PBS Payment Task Force for the Australian Government Department of Health and Aged Care. Paul, that needs a shorter title. It's too hard to say. It needs an acronym. He's a compliance and regulatory expert with almost 30 years in policy and operational experience across multiple federal government agencies, and is currently overseeing the design and development of Australia's government national medical medicines traceability framework. So welcome, Paul. To the panelists, let's start with some questions. So James, first to you. As a pharmacist and informatician, what are some of the key areas where change to 2D barcodes on medicines will improve both clinical and patient perspective? And do you see other opportunities? So 2-barrel question for you up front.
Thanks very much, Barry. Look, Michael's keynote on the Aspen Australia's journey was great to hear and covered many of the manufacturing and regulatory reasons to move to 2D barcodes. Through my lens of applied ordering, dispensing, administration of medications, the starting point is that 2D barcodes mean far greater data density than what we can get on linear codes, which leads to increased accessibility to that data because it's on the medications that the supply chain, the clinicians, and the patients all use. That accessible data provides safeguards for the safe and appropriate use of medications because machine-readable 2D barcodes can be used to provide aspects of checking that a computer is just far better equipped to handle than a person, and greatly increase the speed at which data can be entered into a computer system. As a local example, with the rollout of COVID-19 vaccinations through Queensland Health Clinics, we tested both person-entered vaccine data at the point of administration, as well as machine-read data through 2D barcodes. When a person was tasked with the need to enter the vaccine's batch number and expiry, along with confirming it was the right brand and dose of vaccine for the patient in front of them, it would add 10 to 20 seconds to their process. And typos or omissions on batch and expiry information were pretty common. When all these data points were encoded into a 2D barcode, data entry took less than 1 second, typos were non-existent, omissions were far fewer, and ultimately clinics could vaccinate more people per day. These barcodes create a connection between the physical and digital worlds. A lot of the safety and monitoring benefits of digital health, where I work, are made available through these connections, recording what actually was used and documenting it quickly and accurately. For patient care and medication safety, the encoding of a handful of key data points in a 2D barcode enable several computerized safety and appropriateness checks. In a space of less than 1 square centimeter, a 2D barcode can fit over 2,300 characters. That's more than enough space to encode the medication name or its value, its batch number, the expiry, ideally a serial number, and maybe even an online reference with expanded medicines information, as Marcel mentioned, with the new GS1 digital link format. When scanned, this standard data can be used by clinicians in clinics or in hospitals to confirm that the medication in their hand is the one that's ordered and intended for the patient in front of them, that it hasn't expired, and even potentially to check if there are any active recalls on that batch. And all of that can happen automatically. No extra time spent to gain that value. The same benefits are available to patients taking their own medications at home, with the prevalence of smartphones as mentioned, or for guardians giving medications to those people in their care. A challenge does exist that by and large, these barcodes are only on the outer packaging of the medication. So for many reasons, the outer packaging of a medicine can be discarded and only the falls or the blisters remain. So just a sample here, I've just whited out the branding on this. I'm sure it's a good quality aspirin brand, but branding is irrelevant here. This is about a national standard we want to move to. So in hospital and clinical practice, the workflow is to retrieve the dose that you need for the patient in front of you now and go to the patient bedside and administer it. As such, the outer packaging with that machine readable barcode isn't available when you're actually with the patient. Having as many medications as possible packed into a single unit dose, like 1 tablet per foil bubble, with a 2D barcode on each of those doses, offers the best chance to always have that beneficial computer readable information at the time it can make the most difference, often at administration, but also at key safety checks throughout the journey. Props to Kent for mentioning this in the Q&A, and it's interesting to hear Michael's points on aggregation as well. We ultimately want to have machine readable codes at every level here. I want to go deeper down. Michael wants to go further up. It's excellent. Following on from the point of dispense authentication model that Michael mentioned and raised in the QA regarding the genuine product checking, as a pharmacist, my professional indemnity insurance can become void if I found I dispensed a product and made a mistake and I didn't use a scan check as part of my dispensing process. We have to do it. So to loop back to the question posed, 2D barcodes facilitate computerized decision support to assist the people undertaking medications management, because both the people and the software understand the medication that's involved. Barcodes mean faster entry of key medication data points with higher accuracy, which in turn leads to a richer digital representation of what's physically happened, that then leads to improved safety features for clinicians and patients alike, as well as a bigger base on which to run medication analytics for quality and safety, supply chain surety, and the optimal use of medicines purposes. I'd really like to see Australia move more towards unit dose packaged medications with a 2D barcode on each dose to really unlock some potential here. Thanks again for the double barrel question, Barry, and back to you.
Thanks. Great answer. I really like the fact that there is safety, accuracy, and that shared knowledge that goes all the way across the supply chain so that everybody is more informed and people aren't dropping out, and you can connect the dots all the way through. So thank you, James. Sticking with the medical theme, Paul, a question to you on traceability of medicines in Australia. They've been a topic locally for some time, and your team held a consultation earlier this year. Obviously, there are still some steps to that process that need to be completed, but can you provide us with any updates related to the process? And two-part question for you as well. Are there any key findings that you can share with us so far?
Good morning. Thank you. We did provide a targeted consultation with the supply chain industry late last year, early this year. Obviously, from a government point of view, one of our key focuses in this area is about supply chain resilience. The last couple of years have really kind of highlighted the fact that the supply chain, for a number of different supply chains, particularly pharmaceutical, really is a bit of a haphazard model in terms of visibility of where medicines are at any particular time in Australia. And given that Australia is a very large geographic country, you may have an oversupply in one area, but you may have an undersupply in others, and we just don't know at this time. So that's really why the government is looking into this issue, is really around making sure that the medicine supply chain is resilient, to ensure it has its integrity, and to make sure that we can get medicines to people when they need them, and we know where the shortages are and we can intervene if we need to. In terms of what stakeholders told us, is that essentially they can see the public health benefits, they can see the business benefits. What they want to know is the next level of detail, which is what particular model we're going to do, whether or not we are going to, say, follow the European model, which is very much a point of entry, point of dispense model. We're going to look to do a full model that is a full track and trace through all participants in the supply chain, or something that is a hybrid. There's a few different models that are around the globe. So for instance, the US is doing something completely different, where they just doing standards and then leaving it to the private sector to run their own databases and things. And participants also wanted to know what the time frame was and what assistance there might be from government in terms of cost. So they're the kind of things that we're still working through, and we'll be looking to hopefully come out and do some more consultation with industry in the next little while to actually start to work through some of those issues.
Paul, just to help those of us who might not be familiar with the traceability systems, the point of entry versus full track and trace, what's the difference between those two models?
So point of entry is really when your medicine comes online into your national supply chain. So in Australia, most medicines are imported, more than 95% are imported into Australia. So entry to the Australian supply chain is really at the point of import by the medicine sponsor. And then your point of dispensing obviously is when it's actually given to a patient, either by a community pharmacy or by a hospital. And so essentially in the European model, you have point of entry where the medicine sponsor provides the data for the medicines, in terms of provides your baseline data to measure against. And then when it's dispensed, it's checked against that data to make sure that it's genuine, and to also take it off the system that's actually being given out. A full track and trace would actually mean that every entity that handled that medicine or took possession of that medicine would actually then be required to essentially scan in and scan out to record that they've received it. And then when they're sending it out, they're sending it on. So that would basically mean that not only would it be the medicine sponsor when they imported it, it would then be the distributors, it would then be potentially 2 or 3 layers of distributors, then it'd be public and private hospitals then receive it, and then when it's finally given to a patient as well. And that's a full track and trace, where you actually know where the medicine is at every location that it's actually handled throughout the supply chain. And as I said, there's different approaches around the globe, and that's kind of something that we're looking at the moment.
Thank you, and thank you for helping us understand more about where we might be heading to. Do you have a time frame as to when there'll be a decision made as to how we will take the approach?
Well, we're hoping that the government will make a decision, shortly, in terms of going ahead with this. What that would mean likely is that there will be further rounds of consultation, particularly starting with the supply chain, but then obviously potentially going out to a wider group as well, potentially including consumers, basically to detail out what are the next step, what are the timings on this. If you look at other models around the world, this is normally a very slow process in kind of building these systems out. There's normally a 5 to 6 year kind of rollout strategy.
Okay.
And that's kind of what we're moving towards.
Thank you. I'll move on to Michael to ask him a question. And thank you for your presentation, Michael. Before I forget, there's been a number of people putting their questions into the Q&A function. Please continue to do that. We're happy to answer that, the questions as they come through. Michael, based on what James and Paul have said, what are your thoughts about the implementation of traceability? You've spoken about your traceability program, and traceability or track and trace for products in the local market.
Thank you. I think the ability for pharmaceutical manufacturers in Australia to print data matrix onto pack, and the development of regulations around that is usually the first important step taken, and that's what we've seen in export markets as well. And this is what Australia has outlined in Therapeutic Goods Order 106, which has been issued by the TGA, which actually commences the 1st of January next year, which sort of provides clarity for early adopters serialization and data matrix codes on medicines that are to be supplied in Australia. So that TGO 106 does not mandate the use of data matrix codes or serialization of medicines, but it I guess says, if you are choosing to do this, this is how you need to do it. The fact that the TGA is also going down the path of a standardized GS1 approach to serialization is, of course, a sensible choice and allows for any manufacturers such as ourselves that have implemented GS1 serialization solutions for global markets to more or less sort of be immediately capable of supplying such medicines to the local market as well. So it's good that I guess Australia is going down like that standardized approach, which is of course an enabler for local manufacturers. As I touched on in my presentation and drawing upon examples of the uptake of serialization and traceability in other countries, the adoption of traceability is typically staged in levels of complexity, just due to the fact that the implementation effort is considerable for all stakeholders. So not just for manufacturers like ourselves, but for brand owners, for regulators, and also for the retail or distribution and retail sector as well. So to jump from zero capability to a fully aggregated track and trace system is, I believe, unrealistic to do in sort of one jump due to the entry barriers involved. However, progressing through stages of, firstly, the ability to print data matrix, then moving to serialization at a sales unit level, and then to the reporting of that data to the regulator and through to the retail sector, which closes the loop on authenticity of product. And then finally to the implementation of aggregation, that is the serialization of every packaging unit level and the ability to trace products right through your supply chain and with separate, I guess, milestone dates for each level of implementation, I believe is a more achievable approach. So as Paul touched on before, for the Australian market, I believe the ability to trace where pharmaceuticals are in the supply chain rather than just the anti-counterfeiting and authenticity piece is particular interest and value to Australia. I don't think counterfeit is as big a problem as it is overseas in Australia, and I could be corrected if I'm wrong in that point. So I think really the end goal for Australia really is aggregation, which is, as we understand it, a big undertaking for the sector if looked at its entirety. However, by making a start, by the consultation that's already happening between the TGA and Indian industry, and that continuing collaboration between manufacturers and regulators and distribution and retail, and also importantly by having a standardized, harmonized approach that is using GS1 or global standards, I think it's very achievable and it will create great benefits for the industry, particularly knowing where pharmaceuticals are, where shortages might be, and sort of supply chain issues, across the Australian sector. So, sorry for the long-winded answer. I hope I answered the question.
There's obviously a lot of insights that you guys have gained in your journey. It's my background and experiences in food production and food distribution, and the similarities are very considerable between the medicine and in food, and harmonized capability in a supply chain and being able to share data and just knowing how to share data is a really key thing. It can simply bring the system undone when there's one missing cog who just isn't able to have that harmonized system. So I think that's a really important key piece of insight. I'm going to throw back to each of the panelists and ask them for their headline piece of advice. Knowing what you know now and the journey that you've been on with 2DBarcodes, if you were to open up the newspaper tomorrow and you were given the opportunity to put a headline in, what would you say has been your number one learning or your number one benefit from going on the 2DBarcode? And we might as well, we'll go backwards up the panels. So we will start with Michael.
In terms of I guess, key implementation challenges faced, it's really don't try to reinvent the wheel. It is a complex system to implement. There's a lot of good solution providers out there, and leverage their knowledge and also their ability to provide validation services. So validation is in the pharmaceutical industry, and that might be a term that's not sort of well known outside of the pharmaceutical industry, but that ability to provide documented evidence that everything works and does what it's meant to do, very much leverages solution providers to provide that service to you, and then the whole implementation becomes manageable. That was really the key takeaway for our implementation of a traceability solution.
Okay, thank you. Paul, your headline.
I think what we've discovered is that our supply chains are much more fragile and fragmented than perhaps the general public think. And 2DBarcodes really do hold the possibility for providing levels of insurance and integrity. That means that we can actually make sure that people get products they need when they need it, and we can intervene for levels of supply and safety when needed to.
So a headline?
That's basically the headline.
Okay, it's a long headline, but I'd read that article.
It's a long headline.
Thank James, last.
And luckily so. Look, I think in a nutshell, the headline would be "Meds must be unit dose packed with a barcode," would be sort of the headline I'd go for. I think it's going to be a few hops to get there. Not expecting that to be tomorrow's headline, but it's got to be where the vision is. And I think just agreeing with the other panelists here that information is power. Data-informed decisions are where we need to move, and use the standards. Don't reinvent a wheel here. It's actually fantastic that it's a global trade identification number, and that I could actually conceivably in the near future get medication records from North America and do drug interaction checking and patient safety checks, because we're not arguing over how we spell paracetamol, which we and the Yanks do argue about, but at the core, I do know what that chemical is, and we can work together. We're not, just use the standards. Don't, use the standards.
Cool. Thank you. Well, I would like to thank our panel today, Michael, for both your presentation and for joining us on the panel, for James, Paul, for your insights. It's been really informative. It's great to have such expert views and to be able to share real journeys. They're not theoretical. They're things that you have lived in your day-to-day work lives with real outcomes for us as both providers of products to the Australian public and as consumers. So thank you for your insights. For me, the overall questions, the things that came up with the clarity of the supply chain, the data density, the greater knowledge, the accuracy and the safety to us as consumers, but also as manufacturers and providers of product, and the ability to know where our products are. All of those things are going to make our lives and consumers' lives much easier. So thank you to everybody. For those of you that don't know but would like to know more about the National GS1 Traceability Advisory Group, then you can click on the barcode that is up now on the screen, and you can get information and join the NG tag if you can. I would like to, but to everybody, thank you for joining us today. Thank you for the panelists. It's been an informative session. It's something that is going to change all of our lives. I'd like you to there's a wide range of people that are already part of the NG tag, and it is making a difference to how we're carrying the conversation forward and changing the way that we view our supply chain, and not just as providers of products, but as a collective of companies and individuals that are participating. The more conversations we have around how do we create value in data and sharing with each other, the better off we as industry are going to be, and the better off consumers are going to be, the safer we're all going to be. And it's a great initiative to be able to spread the conversation. So thank you for joining us today, and we look forward to seeing you on future NG Tag webinars.